You might be watching this because you're a patient, have a loved one affected by cancer, or a medical student, junior doctor looking to decipher an oncology clinic letter. My name is Madiha, and I'm a clinical oncology doctor, and here I share things I've learned along the way in the hope that you find it useful too. In this video, we'll discuss 3 common terms used to describe the sequence of treatments in early cancer care: neoadjuvant, adjuvant, and concurrent. Neoadjuvant, systemic therapy that is used before surgery to reduce the size of the tumor and make it more amenable to a smaller operation or reduce the risk of local recurrence. During your treatment, you will have regular clinical assessments by your team and at times investigations such as an ultrasound commonly used in breast cancer care to make sure the treatment is shrinking the tumor. After surgery, depending on the case, you might have more systemic treatment or radiotherapy. Adjuvant is the term used to describe treatment that starts after surgery. Sometimes people use vague phrases like mopping up and belt and braces, but they're not accurate. Patients need to know that only some of them will actually benefit from the treatment. Some have already been cured by the surgery by the time they see us in clinic, and some are destined to relapse despite having all the treatment. Say we take 10 patients in this hypothetical study. 5 have already been cured by surgery alone and don't need adjuvant chemotherapy. 5 will recur despite having all the treatment. If all 10 patients were given chemotherapy, an additional 2 who would have relapsed have been cured. There's no way of knowing which group you're in. The factors will vary depending on the tumor type, treatment, and of course patient choice. This is a discussion to have with your oncologist and weigh up the potential advantages and toxicities associated with the treatment based on the evidence out there. Concurrent chemoradiotherapy. Concurrent chemoradiotherapy is used when combining chemotherapy with radiation therapy to provide a synergistic effect, enhancing tumor control and reducing recurrence. The chemotherapy in this case is referred to as a radiosensitizer. This approach is particularly beneficial for locally advanced cancers where surgery may not be feasible, or as an organ-preserving strategy such as head and neck cancer, anal cancer, or cervix cancer. Normally, you'd start with chemotherapy, and during the first cycle of chemotherapy, radiotherapy would be organized with a view to starting at the same time as the second cycle of chemotherapy. The days on which you have chemotherapy and radiotherapy together are long. In situations where the patient may have a poor performance status, you could consider sequential chemotherapy. If chemotherapy is not appropriate, then radiotherapy can be given alone. Every case is individual and should be discussed in detail with your oncologist. To decide the best way forward, you may consider discussing the evidence around your case. Do the studies show an improvement in overall survival or progression-free survival? What other outcomes were measured and what were the results? How do the combination treatments compare to the single modality of treatments in quality of life? What are the side effects of the treatment, both in the short term and in the long term? And what are the logistics of the treatment? Hope you found that useful. That's all for now.